Hello, good afternoon. I am Dr. Rajasekkhar Pappuu. Today we are going to talk about metacarpal fractures. So metacarpal fractures account 30 to 40% of the hand injuries. So they are most commonly seen among men and elderly women. In men, it is mainly because of punching or any accident, sometimes fall and outstretched on hand directly on the metacarpal neck or anything. And also sports injuries are very common because direct hit while playing sports. In elderly women, there might be usually osteoporotic fractures because of fall. So what is clinical anatomy? So metacarpal is a bone which connects between wrist and the fingers. So it stays in between these fingers and the wrist and forearm. So it is a connecting structure between fingers and the upper limb of the body. It has three parts. One is base, shaft, and also head. And there are different, all the metacarpals have the same anatomical structure. They are numbered from 1, 2, 3, 4, 5. So 1 is first thumb metacarpal, 2 is index finger metacarpal, 3 is the third metacarpal, 4th and 5th metacarpal. So they are numbered according to the fingers they are getting connected. So if somebody says it is first metacarpal, that means it is the thumb metacarpal bone fracture. If it is, they say second metacarpal, that is index finger metacarpal. So this hand has anatomically, biomechanically, it is divided into pillars of the hand. Second and third metacarpals are fixed. So there won't be much mobility between second and third metacarpals. They are very stiff. Whenever we want to move, they don't move. But if you take this fifth metacarpal, it is very mobile. See, if I'm moving this, it moves a lot. But when it comes to the second metacarpal, it doesn't move as much you want to move. And so second and third are stiff, and fourth and fifth are mobile. And they are the most commonly affected metacarpals of all the metacarpals. Other than fourth and fifth, first metacarpal is the other most common metacarpal which is affected due to trauma. So whenever there is a fracture, there are some deforming forces, that is angulation. So we call it dorsal angulation. So what is dorsal angulation? This is dorsal side, this is ventral side. So whenever a fracture breaks in the metacarpal, it usually angulates. It is like this, it angulates dorsally. So that's why they call it dorsally angulated fractures. So metacarpal fractures are classified into head, neck, shaft, base of the fracture. So they are basing on the mechanism of injury. They break either at the head or at the neck or at the shaft or at the base of the. It depends on the mainly on the mechanism of injury. So whenever you put axial load or punching, so then you will have a boxer's fracture. So metacarpal neck fracture will happen whenever you have directly hit somebody or a bag or boxing punch. Direct implant, when something is hitting directly, such as ball, helmet, or falling object, this often produces transverse shaft fracture. So there is a body fracture, metacarpal body fracture, it is transverse. So whenever there is a torsional, so whenever you hold something, when your finger gets rotated or something, when you are holding something and it gets rotated, twisted, that will cause spiral fractures. That is also mainly shaft fractures. And crush injuries. Sometimes, many times we say crush injuries. Suppose somebody is using sugarcane mix. So accidentally their hands go into that sugarcane rollers, and that there it gets crushed very badly, and you have multiple fractures. You will have finger fractures, tendon injuries, nerve injuries, vascular injury, whatever you want to see injury you can see in that crush injuries. And they're very high risky fractures, outcomes are very poor. So mechanism by location. So head, so direct blow to the knuckle or the axle, that is usually communicated intra-articular fracture. So whenever there is a neck, this is striking an object with closed fist. Whenever you hold this and then kick somebody like this or a box, like a boxing punch, that causes transverse or volar. Shaft fracture is sometimes torsional forces. So base is also direct injury. So deforming forces, just now we talked about deforming forces. Whenever there is a fracture, it gets deformed. So that means that fracture gets displaced. So why it gets displaced? Because there are some deforming forces. Every hand has intrinsic muscles. We have forearm muscles which starts from the forearm. They are very large muscles. And you have hand muscles which are very small, tiny muscles. They are called intrinsic muscles. So there are mainly on the palmar side. There are some dorsal side also, but mostly are on the palmar side. So they cause some deforming forces, so that causes angulation. What is the most common clinical presentation? If you take, that is a pain will be there in the hand, wrist, and then sometimes knuckle contour is lost. So see, whenever I show you a knuckle, it is this is first, second, third. This knuckle contour will change. Either it is visible or not visible, and sometimes it might be increased because of swelling. And what is a physical examination? In physical examination, you will have shortening of the finger. So the length of the finger. See, whenever you hold your finger, so they are like this. So they are these length might be changed. It might become too short when you compare with the other hand. What is the imaging diagnosis mainly made basing on the X-ray. We don't do usually CT scan for these fractures, so they are clearly visible on X-rays. After you do a CT scan, you plan oblique X-ray, oblique AP, lateral and oblique X-rays are enough to diagnose these fractures. So common fracture types, what you see, one is boxes fracture, that is fifth metacarpal. Just now we were talking about this. Whenever you hit a punching bag, that will break, and then there will be neck of the fracture. Second one is Bennett's fracture. This happens in the thumb. Whenever there is a fracture, it gets fracture dislocation. So there will be a medial side piece, and the lateral side this will become loose and then gets dislocated. That is called Bennett fracture. Another fracture is Roland fracture. That also happens in the second metacarpal. That is a type of Bennett fracture only. But here, what happens? There is no dislocation, but you see comminution at the base of the first metacarpal. So that's called it is Roland fracture. So see here Bennett fracture, where there is fracture line is on the inner side of the hand, that is close to the second metacarpal. Outer side there is no fracture, and sometimes it gets dislocated. Bennett fracture dislocation, because tendons get attached to the base of the first metacarpal and they pull it out. And here it is Roland fracture, where you see comminution. So these fractures are mainly managed basing on history, presentation. If it is in hand, most commonly used in open fractures. In open fracture, surgery is the only option because you have to do um, uh, debridement, and sometimes in open fractures, tendon injuries, nerve injuries are also associated. So you have to go debride, and then you have exam. You have to examine the hand for any tendon injuries, suture them. Vascular injuries, you have to call a hand surgeon and do suturing of the vessel. So in other than this, in closed fractures, we can do conservative management for this. You can accept angulation up to 40 to 70 degrees for the 50 metacarpal neck, and 10 to 15 degrees for the second, third angulation you can accept. If it is more than that, you have to do surgery. Why 40 to 70 degrees for fifth metacarpal? Because its reduction is very difficult to get. If you have displaced fifth metacarpal neck fracture, it is very difficult to get. So it is always going to 90-degree displacement. So you cannot get reduction properly. So that's the reason why they accept large angles of displacement. Ulnar, what is by if you have a neck fracture, you apply a ulnar gutter split. Surgical technique, there are many surgical ways of operating this. Most common technique is to put close reduction and percutaneous pinning. That is, you put K-wires of 1.5 mm or 2 mm size. Now we have a lot of plates, and also we have specific plates for finger fractures, metacarpal fractures. So we can use plates also. But the disadvantage is there will be a lot of stiffness after surgery, because there will be scarring, tettering, and all that. Best method is to go for conservative, because in hand, whatever the fracture, angulation, whatever it is, function is more important in hand than beauty of the X-ray. Sometimes you will have a very beautiful X-ray, but patient cannot bend his hand and move his fingers. So what, there is no use of a hand which has very good, beautiful reduction but no function. So function is very important because hand has to do a very minute, critical movements to for day-to-day activities. So that's why we give more importance to the function in the hand. So if you operate sometimes only in difficult fractures after surgery, we don't allow them to move the hand. Otherwise, mobilization is done immediately to restore the function because function is very important. And these days we are also having intramedullary screws for shaft fractures. So basing on the surgeon's choice, you can the implants are used most, but most commonly used implant is K-wires, 1.5 to 2 mm K-wires or 1 mm K-wires. Also we can use, or we can put 1 mm multiple 1 mm K-wires. So rehabilitation outcome. Just now we are discussing because function is more important than the beauty of the X-ray. So early motion is critical for any hand function. So you should not pass K-wires through the joint. But sometimes you will not get either reduction or fixation without by without avoiding this joint. So the joint needs to be avoided always, but sometimes you will be in a position where you can't avoid the joint and you have to pass. In that cases, you have to accept the fixation because fracture has to heal for you to get back to the function. Wherever it is possible, we avoid the joint and pass wires from side to the crisscross wires, usually into the fracture. So that is why it is very important to have wires pass outside the joint, not through the joint. But sometimes we can't avoid this. After that, we have to do physiotherapy, but it will take little bit more time. The problem with the hand is whenever you do physiotherapy, you feel that you are not having movement, but suddenly all of a sudden you start getting movement. So you have to keep doing continuously. Hand is very peculiar in this physiotherapy because you think that you are not getting movements. It is stiff. Suddenly, slowly you start getting. Sometimes it might take 3 months, 4 months also. So, but you have to keep on doing physiotherapy regularly, and you will get. So if you are treating it conservatively, 0 to 3 weeks we give immobilization, and 4 to 6 weeks you start doing active range of motion, and after 12 weeks you will return to the full work. Thank you.